the Million Women study that was done on HRT was fatally flawed.
Dr. Renée Hoenderkamp,
NHS GP and one of the UK's most trusted voices on women's health. She cuts through the noise with clear, practical women's health advice.
This is the start of a social credit system. It's wrong and everybody should say no, and I will say no. Major attack on our freedoms, on our physical freedoms, our speech freedoms. So that study did much damage, much damage. It was a massive study.
And on million women?
It was a well-designed study and it was well carried out, but they only started looking at women who started taking HRT in their late 60s.
All of them. Today I'm joined by Dr. Renée Hoenderkamp, an NHS GP known for straight-talking women's health advice on GB News, Talk TV and Instagram. We're busting myths, cutting through noise and giving you clear, practical takeaways. Welcome, Dr. Renée.
Thank you for having me.
We were speaking before and I was surprised to learn that you only qualified in your late 30s as a GP. What made you change from whatever you were doing to deciding, I want to be a doctor?
So I always wanted to be a doctor. My mum had encouraged me. I was in a really rubbish East End school where nobody had any aspiration because nobody encouraged them. But she was there behind me all of the time. And I worked really hard. I got 4 science A-levels. But when I went to my careers teacher, when I woke up one day and I was tired of learning, instead of telling me to defer my place and go travelling for a year, because they didn't really do that then, she said, oh, apply to Marks and Spencer's management. It's really hard. You'll probably get in. And that's what I did. I got in and I hated every single second of it. I felt completely straight-jacketed, couldn't do anything. And I didn't know what to do then because I very quickly bought a house. I think I bought my first house when I was 19 with a 100% mortgage.
Where was that?
That was in, my first flat was in Manor Park in East London, and then my first house was in Dagenham in Essex.
Right.
And then I had my son when I was 21. So I was on that treadmill of needing to earn money. And then I fell into publishing. I did very well in publishing. I was the publisher of OK magazine. I was the ad director of the Daily Express. And so I earned good money and I did well. But by the time I got to my mid-30s, I was like, oh, do you know, I really should prove that I could have been a doctor if I wanted to.
So you definitely knew you always wanted to be a doctor.
Always knew, and it was always there itching. And I was very fortunate because I was able to carry on working a bit for the Express while I trained. So I still had some money coming in. And I did it in a really roundabout way. I did a degree with the Open University in health studies while I was still working in 3 years instead of 6.
Right, wow.
And that enabled me to apply for a graduate entry medical course, which was 3.5 years long.
Right.
So I did it that way. I resat my chemistry and biology A-levels just to make sure I could still do them. And they were so much easier. That's another story.
And what was the grades?
Yeah, I got A's, straight A's in those.
So you resat all your A-levels?
Just the 2, biology and chemistry, because those were the 2.
Yeah.
And they were just so, I hate to say it, but they were so dumbed down to the A-levels I'd taken when I was 18. They really were.
In what sense?
There were no essays. There was fill in the missing words and 2-line answers. And it was, the level of questioning was really, I would say O-level or 11 plus. It was really low.
Oh, maybe I should think about becoming a doctor.
Yeah. So then I got in at Barts. You had to do another exam, which I did to get an interview. And and the rest is history. I went to Barts in London.
So what age did you qualify as a doctor?
So I qualified as a doctor when I was 43. Then you have to do your 2 years houseman, which I did at Barts in London.
For the viewers that are watching, what does that mean? 2 years? What did you have to do at that?
You just have
stage?
to prove that you're reasonably safe enough for the GMC to give you a full licence, so that you could actually.
So is that like working in a hospital?
Yeah, working in a hospital. It's all the junior doctors,
right? The
very very baby ones that you see every August.
So that's what you do for 2 years.
2 years I did that. Then you have to decide what speciality you want to do.
Yeah.
And I did GP.
You did GP. So you're very well known for specialising in women's health.
Yes.
And public myth busting. What made you sort of go down that road of wanting to express views on women's health and stuff from old wives' tales to really what is real and what works, what doesn't? What made you decide, no, I'm not letting all these amazing women listen to this rubbish. I'm going to tell them what really matters and works.
I saw my mum suffer through menopause, and obviously when she was suffering, HRT was going through these waves of being really popular and then really demonised. And I watched the difference it made to her. And then when I qualified as a GP, I saw so many women suffering in silence. They didn't know what menopause was. They didn't know what HRT was. They couldn't access a doctor who knew what HRT was. And I thought, this is just wrong. So I just started going on training courses. I befriended Louise Newson and watched her in action. And it just really went from there.
Yeah, amazing. Because I have a lot of clients that are perimenopausal and menopausal, and some are on HRT and some on HRT. Before we really go into that, out of interest, when you watch your mother she was on HRT, did you know about the components of what she was taking back then in terms of like the estrogen gels and stuff like that?
No.
Or not at that stage. Okay, because I was just interested to know the difference between, you know, the estrogels now and then, because there's been this whether it's a myth or not, and I'm not sure what the studies show, and Louise Newson talks about this as well, is about the cancer side of it, because you know, there were studies showing that the longer women used the estrogen over decades, there was a higher rate of those women getting some kind of cancer. Now, whether that is just coincidence that woman was on HRT or not, would she have got, you know, breast cancer or another cancer? Who knows?
This is it. Women,
and it scared a lot of women.
Yeah, well, there were two things. There were two elements to this. Firstly, the big study, the Million Women study,
Right.
that was done on HRT was fatally flawed.
When was that?
So this was the one that actually, going back 2 decades now, scared everybody. And you saw the headlines on the Daily Mail that women on HRT are, you know, twice as likely to get this cancer and that cancer. And that's when women stopped taking it. They were terrified.
Right. Yeah, because that's the first thing HRT clients say, oh, I don't want to get cancer.
Yeah, absolutely. And the reason it was flawed, and it was done by Cancer Research, it was a massive study.
And a million women.
It was a Million Women study. And unfortunately, it was a well-designed study and it was well carried out. But they only started looking at women who started taking HRT in their late 60s.
All of them?
Yeah. So those women will have already started to develop their heart disease.
All that planning, but who came up with that idea?
Already started developing their cancers.
Yeah.
You know, so it was fatally flawed. So that's how we've now managed to go full circle, that we see now that study was flawed. And we now know that women starting their HRT around menopause, and you actually can consider 10 years as being close to menopause, do not develop their heart disease like they did in the Million Women study. And there are lots of other benefits too, which I'm sure we'll go into. So that study did much damage, much damage. And it's taken a long time to overcome that and to actually be able to access HRT in forms which are not as dangerous. And there are different risks depending on how you take your HRT.
Yeah, interesting. I coach a lot of women with strength training and nutrition that have gone from basically, you know, having Red Bulls and sausage rolls every day and having horrendous menopausal symptoms. But some of them actually say, I just really want change. Just tell me what I need to do. And they're not on HRT because they just either haven't got the money or haven't got access, haven't done the due diligence, and they start training, let's say 3 times a week. They prioritise protein, we work out their macronutrients, and after 3 months, you know, there's stuff on my reels to demonstrate this. They literally just say, this has just changed my life.
Yeah.
The training, I can sleep now. You know, some of the symptoms have gone. You know, I'm not so tired anymore. If I would have been left alone for 30 seconds, I would have fallen asleep. That's gone. You know, the itchy ear, the cold shoulder, all these other symptoms, they disappeared. And it's amazing to see, and their body's changing. You know, they've gone from, you know, all the cortisol sitting in their stomach, and they've got these little sticky out tummies. And actually, some of my female clients in their late 40s and 50s, they've got the nice jawline and shoulders, and they've got these little sticking out stomachs because of the menopausal symptoms, and then they read, oh, I need to be in the park at 6 a.m. throwing big heavy tyres around and doing battle ropes. But actually what that's doing is stressing the body even more, so the cortisol levels raise. And they say, well, I'm eating so healthily and I'm in the park doing this at 6 a.m. Why have I got this stomach? And it's because cortisol is just sitting there and it's just causing the stomach to pop out. Now, as soon as you stop and start eating better, getting your protein higher, weight training, it just changes everything. Anyway, going back to the HRT side of things, some of them have actually not needed to go on HRT because they're like, this is the medicine.
Yeah,
This is the equivalent of putting on a gel, is going to the gym, and they get addicted to it. It's like they can't miss a session.
Well, I was going to say this. I think everything you've just said, there are so many elements to what you've just said. I would defy anyone to not feel better if they start exercising regularly and they start looking at their diet. Yeah. Anyone, be it a man or a woman. Yeah. So obviously that has to always be the start. And most of us come to it later. Most of us don't wake up at 21 and start eating properly. Yeah. I didn't get to it till I was in my late 30s. Yeah. And I wish I'd got to it earlier. Yeah. But it doesn't matter. And I always say this to people, it doesn't matter when you start. Yeah. You can always make improvement. Correct. You can always pay back. It's never too late. It's never too late. Because I think some women do think it's too late. Yeah. Some men probably think it's too late. It isn't. Yeah. And it doesn't matter what kind of state you're in. You can always start. And it's always small changes. And I think the basis of all good health is about exercise and food, without a shadow of a doubt.
Amazing. Thank you. Absolutely correct. Yeah. And it's just proven.
Yeah. Now, all women are different in their menopause journey. I see women that will never have a symptom, ever. They'll never get a hot flush. They'll never get brain fog. They'll never get vaginal dryness. They just sail through it. And that's great. Maybe their diet's really good and full of phytoestrogens anyway, so that it's helping them get through it. Some women, doesn't matter how much they try with food, will get symptoms because it's just, we don't really understand why, but they will.
Yeah, it'll be hormonal. It'll be to do with the levels of estrogen and progesterone and testosterone in them and how it's fluctuating.
And everybody's individual. Exactly. And that's what we have to remember. Everybody's an individual. Yeah. So for those women, they might do everything right, but still need a boost. And that's fine too. Yeah. You know, it's all fine. Yeah. Yeah, it's very true. I take my approach to anything in medicine, not just menopause, is all I can do is talk to you about the positives and the negatives, and then you make the decision. It's not my job to tell you what to do. Yeah. And it's not my job to impose my ideas on you either. Yeah. And that's important. And lots of doctors do impose their ideas.
Yeah. So let me ask you this. If I was a 45 to 50-year-old female that came to see you with either, severe perimenopausal or menopausal symptoms, all the side effects you've just mentioned, you'd probably want to see a blood test. Maybe would you be saying, right, go on HRT, or would you be saying, have you tried training? Have you tried prioritizing food? What would your recommendation be?
Always, I'm going to talk first about diet, phytoestrogens, polyphenols, getting the gut right. And I think actually going back to what you were saying, gut is an important part. So important. And we can come back to that on PCOS actually. Yeah. And training.
Healthy gut, healthy brain.
And healthy body. Yeah. I mean, just all of it. But I would always talk about that first. But again, it's up to the woman. Is she going to be able to do that? Has she got the time and the wherewithal? You might say you must have the time. But, some people just don't feel able. But I'll always talk about that first. And then the choice is hers. And most women, I think, would say, okay, well, let me try. I had one last week. And she said, all right, I've written that all down. This is what I'm going to do. And if it doesn't work, I'll come back. Yeah,
because also a lot of it, male and female, but if we're on the subject of females with HRT, it's to do with mindset, because it's the longer, harder route. It's not, you can go, right, HRT, fine, go and get it, and then start applying it, and, within 2 or 3 weeks, you should start to feel better. As opposed to, right, you've got to start training, you've got to prioritise protein or just your macronutrients. That is... You've got to get to the gym, you've got to train for at least an hour, let's say 45 minutes. But that's not 2 or 3 weeks. That's week on week, month on month to see progress and change. It's tougher and it's up here.
Well, I think that's really interesting. And this is what I try and say to patients is I think that whenever you start anything new, now be that having a kombucha every day or be it going to the gym every day, your brain doesn't want to do hard things.
Yeah.
It's a natural protective process for your brain to say to your body, no, don't do that, it hurts or it's hard.
Yeah.
And I think it takes about 3 months of repeating that thing that your brain is telling you is too hard before your brain goes, oh, okay then.
Yeah.
And I call that my head gremlins. And I used to get it.
Yeah.
I used to go on the treadmill and my head gremlin would say, oh, you're too tired today because you didn't sleep very well last night. Or you haven't had enough carbohydrates, so you haven't got the energy. Or your period's coming and that's why you can't do this. You should stop. And I would stop. Now I still get those thoughts, but I don't hear them. They're quiet. They're at the back.
You just get on with it.
Because they're my gremlins and I know they're my gremlins and I know not to let them win. But it takes a long time, I think, to get to that point.
Yeah. Yeah, I mean, I started to really focus on helping women because someone very close to us was 44. And it's amazing still to think that as much as this is talked about, some women just don't know about it and what's happening and what's going on.
They really don't.
I was in my office just working and she was here talking to my wife, crying about she just couldn't get up in the morning.
Yeah.
Like her head was saying, get up, but the body was saying, you're not moving, can't get up. And she would just throw herself on the floor and get up and very, very tired, exhausted all the time. And this is someone that really took her training seriously. She was running a lot and not much weight training, but that's another story. Where we used to tell her, don't do so much running, start lifting weights, right? Anyway, and I just sort of came and said, I've got to interrupt. What's happening? As I could hear about the tiredness, fitness, maybe I can help. And she just said, well, yeah, I'm really exhausted. I went to the doctor 6 months ago and the doctor said, let's have a blood test. And the blood test was fine. So take these antidepressants. I said, okay, do you have a copy of the blood test? She said, well, yeah, I didn't really even look at it because not a lot of these, whether women or men, look at really because it's just numbers. And you're not qualified, and I'm not qualified, but I know what I'm looking at from all the research I've done from being an online fitness coach. So the first thing I wanted to look at, I just didn't even read anything, literally, was her estrogen levels. Straight away, 0. The number said 0. So I didn't know at that second of that time, I didn't want to have a worried face and look at her, because where she would think, why does he look worried?
Well, at 44, that's unusual.
Well, yes, and it was early. So I said, did the doctor say anything about your estrogen level? And the doctor, she said, no. The doctor said, everything's fine. You just should try these antidepressants and come back.
It's bizarre to actually test something and then not act on it.
They just wanted to see her blood. Anyway, so she said, I said, look, you've got estrogen is 0. I said, don't take my word for it. You need to go on HRT. I mean, you can start weight training, but at that level, you need to see an HRT specialist. Go and see Dr. Louise Newsom's clinic. I suspect you're going to need estrogen, you're going to need progesterone, testosterone. Don't take my word for it. Take this blood test. Anyway, fast forward. They agreed with everything. She went on HRT. Within a month, her life had changed. She came here crying again, but this time it was to put her arms around me and say, you've changed my life. But the moral of it was, she didn't really know what was going on. And the GP she went to see said, take antidepressants.
So
I thought that was just bizarre.
It's bizarre. I mean, look, I have a whole thing about antidepressants. There's really no evidence that antidepressants work for anyone, let alone a woman in menopause. They can actually lessen hot flushes a little bit, it would seem.
Right.
But they're not going to solve all the other problems of menopause. And I actually think that the first thing to go in a woman before she even realises, and quite often once she turns 40, is mood and anxiety.
Yeah.
Now, mood and anxiety can be helped dramatically by exercise.
Yes.
We know that.
Yeah.
But of course, if you're really low, then you don't feel like doing it. It's that vicious circle.
Getting up.
It's like period pains.
Yeah.
The last thing you want to do is get up and exercise when you've got period pains, but actually it really helps. But the problem that we have is still this awareness, and we have gone, Louise has been a major, force in this. We've gone forward majorly in people understanding, But still, many women, I get them in front of me and they give me every symptom of menopause, but don't think they're in menopause. They think they're dying of cancer, and
Really?
yeah, it's really common. And the thing I see most often is I'm just not myself anymore. I want my old self back. I hear that all of the time. And then when you get it right, be that with diet and exercise, HRT or both, they come back and they say, I've got my old self back.
Yeah.
I feel like I did.
Yeah. Amazing. And how is it at the moment in terms of the path getting onto HRT on the NHS? So if you said, right, yeah, you need to go on HRT tomorrow, what would I do next?
I'd just write you a script, tell you how to use it, and off you'd go.
So it's easily accessible on the NHS.
It is, and we seem to have got over this shortages. We had a period where there were real shortages of gels and sprays, but we seem to have got over that now.
Right.
So no, it's not hard, but you do need a GP behind the desk.
Who knows what they're talking about.
Who knows what they're talking about.
Yeah.
I mean, to give you an example, I had an email from a GP the other day talking about an 80-year-old who'd been on HRT since she was in her 50s. It had been stopped because she had surgery, because she was on a tablet. And the blood clot risk. And with the tablet, there is a blood clot risk.
An estrogen tablet?
A mix, yeah, combined.
With
and
what?
they'd stopped it, progesterone.
Right.
And it had been stopped. But the surgery was all done and gone now. And she felt terrible. And some women will. Some women will keep their symptoms for life. And she wanted to go back on it and the GP wouldn't let her. And so they emailed me and said, would you let an 80-year-old go back on a tablet? And I'm like, she's 80. She's been on this tablet for 30 years. What are you scared of?
Yeah.
Have you explained the risks? And surely it's her choice. And that is always my view. If you explain the risk to somebody carefully and say, you are at high risk of a deep vein thrombosis or stroke with a tablet, and they still want to do it, document it carefully and let them do it.
Right, yeah. As opposed to, why couldn't they just put her on a gel?
She didn't want a gel.
She didn't want
it
to.
didn't suit her life. She wanted the tablet.
She wanted to stick to what she knew had worked. Yeah, fair enough. Okay, let's go from women to men on replacement therapy. So for the viewers that don't know, HRT stands for Hormone Replacement Therapy, and specifically for men, it's TRT, which is Testosterone Replacement Therapy. Now, I mean, correct me if I'm wrong, because you would have probably seen, you may not have, but men coming to you with symptoms that show signs of low testosterone and what it can and can't do for men. Because from my perspective, I've seen, not only do I coach a lot of men either on TRT or that need TRT but don't know it yet, but there has been, it's linked with, I think, mental health, where men's testosterone gets so low. It might have been low to begin with, but as they're getting older, it's getting worse. There's been suicides and all sorts of horror stories, and then they've looked at bloods and testosterone levels of a 45-year-old male. He actually had testosterone levels of an 80-year-old, and when your testosterone levels are that low, I know from experience 10 years ago when I had very low testosterone, you are effectively depressed. There's no energy. You can't get up. Your head's telling you go and play with the kids in the garden, but your body's saying not moving.
Yeah.
My question to you is, from my due diligence and the male clients that I train, it is still a taboo subject in this country. But what I've seen is, I won't mention the names, but I've seen some big sort of blood-taking companies team up with some male testosterone replacement experts, and there are some clinics coming up now and for men. But the difficulty I've heard over the past, which has got better, is access to the testosterone, as opposed to a woman coming to you, you say, right, you need HRT, and within a week you get a prescription, you got it. Here, what would you do for a male with the same age, 45, chronically low testosterone? You've seen the bloods. What would the answer be from a GP doctor?
Well, I think the answer, if I'm honest, is going to be, we'll do your bloods. And if your testosterone is below range, I don't even mean low, I mean, below normal range. So we're talking about below 8, somewhere around there, because that's where the NHS level is.
Yeah.
Then we'll refer you to endocrinology. That will take a year.
A year.
At least a year, generally.
And what would a year for what?
For endocrinology to diagnose low testosterone that needs replacing.
Why would it take a year for that one specific person? They'll get a blood test.
Because that's how long referrals take now. That will be postcode specific. So in some areas it might be quicker, but where I am, it will take a year. And they're not going to get treated unless they're below range. So you're absolutely right. You might be in range, but your range might be really low for a man of your age.
Yeah.
And that won't get acted on.
And am I right in saying the NHS moved the minimum level up about 4 or 5 years ago?
Oh, I don't know, but it's low. I mean, the minimum level, I think, from memory, because we don't often do testosterone for men anyway, and I don't see that. I see more women than I do men. Is only about 8.64, something like that. That's the bottom range.
Yeah.
And there's no recognition of age in that.
Right.
None at all. And there's also an acceptance, even with private blood companies, I know this, that once you're over 50, the expectation that you'll have low testosterone is higher.
Right.
So you'll get told that this level might be okay if you're over 50, but if you're under 50, it's probably low.
Right.
And we do see that. And you're absolutely right about suicide, because when do men commit suicide? When they're in their teenage years or when they get to 50.
Yeah. And that's, and we'll never really know.
It's andropause, isn't it? Let's give it the name that it is. It is andropause.
Right.
It is the menopause for men.
Yeah.
And the symptoms are very similar. So you see, men get very similar symptoms, even down to hot flushes.
Yeah.
And we see it with men that are being treated for prostate cancer and have to have their testosterone suppressed. They get menopause symptoms.
With prostate then, for that, do they get prescribed a testosterone? No. Why is that then? Is that a money thing, do you think, or?
I don't think it is, if I'm honest. I think it's just this fear, and we see it in women as well when they have breast cancer, that suddenly everybody panics and they get taken off of estrogen, even if their breast cancer is not an estrogen positive breast cancer, if you believe that that's what drives the cancer, and that's a whole nother debate. There's a very good book called Estrogen Matters that debunks that theory.
Right.
There's this fear, of course, if someone's got prostate cancer, it's caused by the testosterone, or that can stimulate it, so you then suppress testosterone.
Is that the case?
I guess it could be. The theory that Professor Blooming has on estrogen and breast cancer, for example, is that we have estrogen receptors all over our bodies, on all sorts of cells that grow with time. If you've got a breast cancer cell, there's every chance that it will grow an estrogen receptor, even when it's got a cancer in it. That doesn't mean that estrogen is feeding it. It just means that it's a cell that's got a cancer in it that's making it grow, but it happens to have an estrogen receptor.
Right.
You know, the jury's kind of out again, because as you said with the Million Women study, and this is the same for men, once you get to a certain age, you're more likely to develop prostate cancer, breast cancer, endometrial cancer. So is it the hormones that are driving that, or is it that you would have developed that cancer anyway?
Right. And from a clinical doctor's perspective with prostate cancer, is it linked with testosterone? Is it to do with an amount of testosterone in your body that's driving the prostate to get enlarged, or how is the level of testosterone linked with?
Well, that doesn't marry, does it? Because men's prostate gets bigger as get bigger as they get older. That happens naturally. Yeah. But their testosterone is going down.
Yeah, it's true.
So those two things don't marry. So I don't pretend to be an expert on prostate.
Yeah. Okay.
But that for me, logically, that doesn't work.
Yeah.
I mean, I think genetics seem to play a very big role in prostate cancer.
Right.
And we've seen that. You know, if you've got a father who's had prostate cancer, you're twice as likely to get it. If you're black, Afro-Caribbean, your chances of getting it are much, much higher.
Right.
So there's a big genetic input.
So would you say that the NHS don't support TRT for men at the moment? Yeah.
Yeah, I mean, look,
I would as well.
Yeah, without a shadow of a doubt. It's the only person I know in our practice that has had testosterone, has done it privately.
Yeah.
And then we've taken over the prescribing.
Yeah, which unfortunately not everyone can afford, because, I mean, I was going to ask again, what should the bar be for diagnosis and treatment? If you think you have, to any male out there, if you think you've got low testosterone, your libido is very low, your energy is very low, you've got no get up and go, what?
I think it's a really simple answer to this question, and it's exactly the same answer for women in menopause. Try some replacement and see.
Yeah.
And if you try it and it works, you feel more energized, you've got libido back, your mental health is better, you've got your answer.
It's true.
And it's the same with HRT.
Yeah. Yeah.
Because if you're so low on testosterone that you can't exercise, because you just can't, then how do you're in a vicious circle, aren't you?
Yeah, it's true. And for men working with me, we focus on progressive strength, protein targets, sleep. I mean, it goes back to what we were saying before, but that supports?
Of course. It's got to be the fundamentals, hasn't it?
Always.
You've got to get back to food.
Yeah.
I mean, you mentioned...
It plays such an important part. People don't realise how powerful it is.
They really don't. And so one of the things that women suffer as they get older, so naturally as they get into menopause, but actually as they get older, is joint pain.
Yeah.
Yeah. For me, it's these. It's my
Right.
thumbs, both of them. Awful. Some days worse. If I've got a virus, they'll be worse because it's inflammation in the body.
Yeah.
And they come and ask about menopause because they want to get rid of their joint pain. And I'm always quite honest about this. And I always say to them, look, as your estrogen goes and your joints get less lubricated, because estrogen is a lubricator, they will hurt more. But please don't leave this room thinking that just taking HRT is going to fix your joint pain. It might help it not get worse. It might help it a little bit, but it's not going to solve it.
Yeah.
The only thing that's going to solve it, or at least make it more bearable, because we've kind of got to accept that we're getting older.
Yeah.
And there's wear and tear, and people are in denial over this.
Yeah.
Exercise and strengthen the muscles around your joints so that there's more support.
Yeah.
Eat an anti-inflammatory diet, which was one of the reasons we talked about sugar earlier. I got rid of sugar in my diet because sugar is evil when it comes to inflammation.
I agree. And
keep the joints moving, because, I mean, my knees are okay as long as I'm exercising.
Yeah.
If I'm not, I get pain. And so I don't want people to think that either testosterone or estrogen is the answer. It's the be all and end all.
Yeah.
It's always a combination.
There's a physical aspect.
It's physical, and food always is going to underpin that.
Yeah, yeah. Let's park hormones for a moment and have a quick chat about mental health. When to seek help, how antidepressants fit, and what you can do this week if you feel really low. I ask this because I coach men and women, and there's a couple that, one individual suffered with really bad depression and anxiety. He was a 22 stone, 6 foot guy but not muscle, was just extremely overweight and unfit, and he made that decision. No drugs, no injections. He joined and he lost 25 kilos. He's now 17 stone in about 4.5 months, just from training, eating, sleeping, repeat. Again, he used to drink quite a lot of booze, had crap food every day. I gave him the nutrition plan, so we've gone from bacon butties to yogurt, oats and berries, and he's having tuna salads at lunch and chicken and rice and all this whole food stuff, and his whole life has changed.
And his mental health is better.
It's better, but he suffered a lot. He does, I think, still take medication when it comes on thick and fast. But training and changing diet did help a lot. What's your current stance on antidepressants? What do you wish patients knew before starting and stopping?
Okay, so the antidepressants that we use in the NHS really are SSRIs. Yeah. Selective serotonin reuptake inhibitors. And this is on the basis, the theory, that if you're depressed, You don't have enough serotonin in your brain. And so this makes it hang around for longer. There's very little evidence for that theory, by the way.
Yeah.
But it's the theory that the drug companies have sold it all in for. I'm not going to sit here and say that they don't work for anybody, because as you rightly say, you know, your guy does need some help at some points. And I have seen some people. Now, how much of that is placebo? I don't know, because I think a lot of it is. But I'm taking a tablet.
It's making me feel better.
Yeah.
I think it's making me feel better.
Yeah. But I think in the main, most people won't benefit from an antidepressant. And what worries me about SSRIs is there are lots of side effects that I think doctors very rarely tell people around. The biggest one being sexual dysfunction.
Right.
And sexual dysfunction is a massively big problem on an SSRI. Loss of libido, inability to ejaculate. And these are big problems for mental health.
Yeah.
Sex is really important for mental health.
Yeah. Can make it worse.
Yes, physical intimacy is really important for mental health. So if you don't desire that anymore because of the tablet you're taking, I fail to see how that's going to help your mental health.
Yeah.
There is also a cohort of people that suffer from that forever, that it never goes away, even when they stop taking the tablet. It's called post-SSRI sexual dysfunction. And the drug companies only acknowledged that that existed about 5 years ago.
Right, I didn't realise this was such a big side effect.
It really is, and they absolutely refuse to acknowledge it, and now they do.
Right.
So you risk losing your sexual...
Is that because lots of people have come back and said, I'm taking a work, but the bedroom is not working
It's
anymore.
not working. And imagine that forever.
Yeah.
You know, so I think these are risks that really need to be explained. And then I think we need to talk about patients as you do, or to people as you do, about other things that they could do. But that's hard.
Yeah.
And we are in a society where we really do want the pill. We want the pill to fix it for us.
Yeah.
Be that a fat pill,
Yeah.
be it an antidepressant,
Yeah.
be it an antibiotic for the cold you've had for a day. Believe me.
Yeah.
You know, and so we need to somehow get our children, because it's no good with adults, it's finished, get our children into the understanding that they shouldn't be looking for a pill. They should be looking inwards.
Yeah.
And teaching them how to do that.
Yeah.
And we don't do that. We do it very badly. So I would say that, yes, of course, I don't want people committing suicide.
Yeah.
So I would always say you need to talk to someone else. You need someone there, a bit like AA, but for mental health, that you can turn to when things are really, really low, who can say, come on, Matt, let's go for a walk.
Yeah.
Let's go for a run.
It's funny, yeah. It's uncanny you said that. A female client, younger, in her 20s, who's done amazing. She's lost 14 kilos. You know, she was 90 kilos. She's something like 75 now. Messaged me yesterday and said, Matt, I'm just crying in bed today, just full of anxiety. And she said, I feel terrible on you and me. I can't go to the gym. I said, don't worry, forget the gym. All I want you to do, and this is an order, is get up, go outside and have a walk. Yeah. Just go and, with your partner, go and have a walk in the fresh air, forget the training, and then have some food. And then, she messaged back a couple of hours later and said, I feel a bit better now.
The evidence is overwhelming that if you can spend 10 minutes a day outside, and not in your garden, just in the greenery in a park or an open space.
Yeah, that's why I said it, I know.
The benefits
it helps me
mental
sometimes.
Health.
You've had a long, busy day. You just need to...
Just go for a walk.
Go for a walk.
Yeah.
It's either that or the cold tub at 3 degrees. You want to try that?
Apparently it doesn't work so well for women.
No, I know. Let's not go into this. We'll have an arm wrestle over that.
I'm going to go with that, so that I don't have to do it.
My wife, that's her excuse. No, it's no good for women. I'm not getting in it. But anyway, okay, right. To finish off, I've got some quick fire mythbuster questions for you. Collagen, worth it or not?
Yes. And I've come to this late.
Yeah.
And I take collagen every day now in my yogurt that I have every day for lunch.
Right. And
I have 100% natural yogurt. I don't believe in zero fat or reduced fat foods. Got to have full fat.
Fair enough.
Seeds, mixed seeds, collagen and pomegranate, and sometimes fig.
And what do you think? So if I removed collagen from, so if I secretly removed that from you, what do you think? What different negative differences do you think you would see?
Okay, I would see it in my gut and my bowel movements, and I would see it in my joints.
Have you tested that? Because that will be to do with fibre, won't it?
I don't think so. I think it's about a healthy gut. I don't think fibre, I think obviously fibre is important, but I think that it's about a healthy gut microbiome, and I think collagen changes that. And I think that joints definitely helped. I think menopausal women should all be taking collagen.
Yeah, I was going to say there'll be a difference between men and women. So I'm interested to know then, before, how long have you been taking collagen?
6 months.
6 months. So what, did you have bowel issues before that?
I always had to take extra fibre.
Right, so since taking it, it's...
I don't need to.
You don't need that either, so it's
Don't
just
need the
improved
extra fibre, yeah.
Okay, very interesting.
And
to
my
know.
joints are better, for sure. And my other half...
I've learnt that today, that's good.
My other half, who is 60... God, he's going to kill me if I get this wrong. 4, says it has made a major difference to his knees.
Okay.
And he's a cyclist, and so...
Yeah, you always keep learning. Good. Non-negotiable basics of sun protection for people in their 40s and 60s.
God. So
Because I'm calling you up on this because of some of your reels and stuff.
I know, but this is really hard for me. So I've already had 5 basal cell carcinomas removed.
What's that?
5 skin cancers.
Oh, right.
Okay.
Did you sunbathe a lot?
Yes.
Unprotected?
Yes.
Well, no cream?
Or a very low factor oil. I used to burn myself to a crisp as a teenager and in my 20s.
Oh, right.
Because we didn't know then. And I believe, because I'm very fair, I don't go very brown naturally. This is about it, actually. This is my natural brown.
Right.
I used to believe if I burnt myself to a crisp on the last day with no cream, it would turn brown when I got home. Never did, of course. But now I've had 5 basal cell carcinomas. So I know the damage I did then is showing itself now. So I have got a completely natural sun cream now, because I got so many people nag me about sun cream.
For holidays, or do
For
you mean
holidays.
every day? Right,
No, I don't use anything
Right.
every day.
Yeah.
But for holidays, because we go to Spain a lot, through a lot, I've now got Green People. They do a nice one. And, oh goodness.
50?
Yes.
So always 50?
Yeah. And I put it on every morning before I even leave the house when we're on holiday. And my little one, who's got red hair and blue eyes and lily white skin.
Oh, you've got to be at 50.
Yeah.
Yeah.
I think,
okay.
you know, but I get castigated about this.
Yeah, I've learned this. I've put 50 on now.
Right. But people castigate me that I'm covering myself
And
in
I get brown.
toxins. Yeah, I get brown.
It's that debunks that theory. If you put a 50 on, you won't get brown. I come back.
Oh, no.
Colour.
Absolutely. I put 50 on every day and I go as brown as I will go. And this is it, because I'm fair. So, yes, I do use sun cream. And I get lots of trolling on this.
It's all right. That's part of being online. Decongestant sprays long term.
No. So, steroid spray, okay. And the best one for the least systemic absorption is mometasone.
Right.
But decongestants, evil, shouldn't even be sold.
Really?
And you can hear me. I suffer.
I got to bring you up on that, because rarely, if I get a really bad cold or whatever it is, if I just can't breathe through my nose, I'll leave it for 1 or 2 days and just, you know, do a steam room or whatever and hope
Neti pots.
Yeah, but if there has been over the years where I've got a really bad cold and it's just blocked like cement for 4 or 5 days, I'll use one of those sprays.
For how long?
Just, don't know, a week until it goes. But you can breathe within like a minute, and feeling of like, and then like you just wake up as well because you've got air in your lungs.
But that's the problem, you see, because they work so well, like the Otravines of the world.
Yeah,
they work
that's it,
so
Otravine.
well. But
what's the negative then?
Because you then get a rebound after about 3 days. You get a rebound sinusitis, so then you can't do without it because it just self-perpetuates. There are stories of people that have been on them.
I've heard that before.
Well, you're lucky. There are stories of people that have been on them for 10, 20 years because they can't stop using them.
Oh. Yeah,
So that's why I'm so scared of them. I do have a very good friend, Bernie, who we have this conversation. I don't tend to get those colds, you see, where I'm totally blocked.
Right.
But she does. And she says, no, I have to have it for a couple of days.
Yeah.
But no more than 3 days.
Yeah. So well, maybe, yeah. I would agree with that. And then the last one. So one change that would instantly improve women's outcomes in the NHS.
Well, it's got to be just easy access to good menopause advice. But I think also I would extend that to hormone advice generally. I think we're just really bad at it.
Yeah.
And I said to you about PCOS. There's really good data now coming out, Matt. I've been asking myself why more and more women seem to have PCOS. Is it because PCOS is on the increase and that's driving obesity? Or is obesity on the increase and that's driving PCOS?
I'm very interested to hear about this because I've got clients with PCOS, so go
Right,
for it.
and I don't know the answer to that question, but there's good data coming out now that it's about gut. And it's about leucine,
Yeah.
that you need the right gut microbiome
yeah.
to convert that into the right hormone balance. And women with PCOS do have a particular gut missing. I think I've got a vlog coming up on this soon. A particular gut microbiome missing, whose name I can't remember right now, that doesn't do that conversion.
Right.
And that's fascinating, because if we can get on top of that.
Is there a fix for that? Is it to maybe eat more fibre or any type of macronutrient like that?
Well, I think it's just total diet transformation. And it is about fibre, but it's also about take a probiotic.
Yeah.
I mean, I like Simprove.
Right.
I really do.
Simprove?
Yeah, Simprove, the daily drink. Yeah.
Oh, the drink, right.
I mean, there's some good data from UCH that said it's really the only one of the regular, like the Yakults and all of that, where it actually gets to your gut, actually makes it to your colon. Take a good probiotic, get all of those macronutrients in. We can do this for ourselves.
Yeah. Interesting. Wonderful. Doctor, I think you've been fantastic. It's been absolutely delightful to have you on my podcast. Maybe we'll do it again. I think you've been brilliant. You can catch Renée on her Instagram, which we'll bring up on the reel, and on GB News and Talk TV. Thank you again.
Thank you.